The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I am Leslie McGee with the Adult Protective Services Technical Assistance Resource Center. Welcome to today's presentation, Care Coordination at APS Case Closure, a promising practice for caretaker neglect. Hopefully, we may get some preliminary answers to that question today. Next slide, please. Before we get started, I want to cover a few things. NAMERS and the APS TARC are a project of the U.S. Administration for Community Living, Administration on Aging, Department of Health and Human Services, and administered by WRMA Incorporated. Contractors' findings, conclusions, and points of view do not necessarily represent the official policy of the U.S. government. The models and information provided during this webinar do not serve as official guidance to comply with any part of the APS final rule. All information provided is done so for informational purposes only. Next slide, please. This webinar is being hosted by the APS TARC. We work with states to enhance the effectiveness of APS programs by supporting our partners' use of data and analytics, applying research and evaluation to practice, encouraging the use of innovative practices and strategies, and providing APS programs with individualized technical assistance. Bottom line, we are here to help in any way that we can. Please just reach out to us using the contact information that will be displayed at the end of the webinar. Next slide, please. Please use your computer speakers to access audio for this webinar and make sure the volume is comfortable for you. If you experience audio problems, we have found that exiting the webinar and re-entering will resolve most issues. If you continue to have problems, please message us through the questions box and we will try to assist you. Everyone is muted for this webinar. You may ask questions of our presenters at any time by typing them into the questions box. We will relay as many questions as we can to our presenters when we pause for questions. Next slide, please. All attendees will receive an automatically generated email approximately 24 hours after the webinar ends with a link to your certificate of attendance. This webinar is being recorded and all registrants will receive an email when the recording is made available on the APS TARC YouTube channel. Handouts and slides for today's presentation will not be made available at this time. Next slide, please. Now we're going to run our poll that we always do to get a makeup for our audience. I'm launching it now, and you may vote by clicking directly on your screen to select the position you most identify with, the profession, I'm sorry. We'll keep it open for a bit to give people an opportunity to respond. Okay, we had about a third of the people have voted. So I'm going to give us a couple more seconds to try and give everybody a chance. Okay. It looks like just about everyone who's going to respond has done so. So I'm going to close the poll. And as you can see, we have about 80, oh, I didn't share it, sorry. About 84% of you represent the Adult Protective Services professional field. And we have a couple of people here who identify as something other than that. Thank you for responding. Now, our presenters today, whom you see on camera, are Courtney Reynolds, Dr. Farida Ijaz, and Dr. Samantha Tuft from Benjamin Rose, and Tiffany Conway from the Utah Department of Health and Human Services Adult Protective Services Program. At this time, I'm going to turn it over to Courtney. Thank you.
Thank you. Next slide, please. So today we're going to be presenting about our care coordination project at APS Case Closure and whether it's a promising practice for caretaker neglect. Next slide, please. This is our disclaimer. The work that we're talking about today was funded by the Administration for Community Living, but the points of view that we express or the opinions we express do not necessarily represent official ACL or DHHS policy. Next slide, please. So this is the agenda that we're going to cover today. First, Dr. Ijaz is going to give you a project overview, and then Dr. Tuft is going to talk about some preliminary findings. And then Ms. Conway is going to talk a little bit about the impact of the project, and then I'm going to lead the discussion, and then we'll have a little bit of time for questions and answers at the end. Next slide, please. So without further ado, Dr. Ijaz.
Good. Next slide, please. So our project partners were Benjamin Rose. We were the lead agency, and we partnered with Utah HHS, which really specifically adult protective services, as well as the U4A, which is the umbrella for the area agencies on aging in Utah. Next slide, please. So caretaker neglect is defined very similarly to caretaker neglect in other states. And it's basically the failure of the caretaker to provide necessary care, including food, shelter, supervision, clothing, and health and medical services. Next, please. So why did we focus on caretaker neglect? We did so because it's the second highest type of abuse reported to Utah APS as well as in the US. The first highest in Utah is financial exploitation, whereas the first across the nation is self-neglect. There are few studies only that have examined how caretaker neglect from an APS perspective, client perspective, affects the client and perhaps the alleged perpetrator or the caretaker. But we know from the limited research that it has a negative impact on health and can lead to death. There are other caregiver studies that have similar outcomes which are not APS focused. Another interesting fact about caretaker neglect is that it can be intentional or unintentional. And that's one of the reasons why we wanted to look at it, is how we can help people who may be unintentionally neglecting their care receivers. The other interesting fact about caretaker neglect in Utah is that almost more than 3/4 of the cases, almost 3/4 of the cases are inconclusive. So but they still reoccur. They come back into the system. So we were like, what can we do to prevent the reoccurrence? Next slide, please. So our goals was to develop a post-APS case closure. We didn't want it to be during the APS investigative process because we didn't want to interfere with that process. And the eventual goal was to prevent reoccurrence. So we started as soon as a case was closed by offering case management to clients with an allegation of caretaker neglect as well as their alleged perpetrators. So this makes our study pretty unique. There are very few research studies that have looked at the dyad of both the caregiver and the care receiver, or the alleged victim and the alleged perpetrator. But in our case, since the case is inconclusive, we are calling them clients and caregivers or caretakers. And we wanted to link both clients and caretakers to home and community-based services and supports, so that going to our second project goal is that we wanted to improve client and perpetrator outcomes, including some psychosocial measures like depression, anxiety, as well as higher increase of home and community-based services to prevent reoccurrence. Next slide, please. So in terms of eligibility criteria for our study, we looked at those 18 and older because Utah APS focuses Utah APS, unlike some other states like Ohio, can deal with adults who are 18 and above, not just older adults. They had to be reported to APS for caretaker neglect, and the case had to be closed as inconclusive because we didn't want to interfere, like I said, with the investigation. They had to live in Utah, live in the community. We didn't focus on residential care clients. They had to have a working phone number because this was a phone-based intervention, a case management intervention. In terms of the perpetrator eligibility, most of these are the same as the client, except for that we looked at only at unpaid caregivers, we didn't look at the formal caretakers. The other interesting thing was that they should not have had any APS supported cases for any allegations during the study period. And we expanded it from the alleged perpetrator to include those who might be the most important primary caregiver in the client's life. And we did this because clients often told us, yeah, that person was listed as the alleged perpetrator, but he or she doesn't really, but they don't really help us with anything. We need help, our caregivers need help. Why don't you call my daughter or my son? So can we turn to the next slide, please? The study, like I said, was a phone-based intervention. So it was case management intervention offered in all 29 counties of Utah. Next slide, please. The study design originally was supposed to be a randomized clinical trial, but because we were having difficulty recruiting the sample over the phone, considering that we were, there's so much about awareness about scams now, and the fact that we were offering a gift card to clients and clients for participating in the study. So it was a 4-month intervention. The pre-test and the post-test was conducted by a research assistant. Right after the pre-test baseline research interview, the care coordinator, Tiffany on our call, started a needs assessment and developed an individualized care plan and followed up with clients 30 days, 60 days, and then 120 days. The interesting thing is that the care coordinator could call the client multiple times, but the formal documentation was done on these dates, 30, 60, and 120 days. Next slide, please. Now I'll turn it over to my colleague, Dr. Tuft.
Thank you, Dr. Ijaz. Next slide, please. So here are some demographics of some of the preliminary findings that we have, these early findings. So we have 37 APS clients and 31 alleged perpetrators and caregivers. So the median age was 62 years old for the APS clients. There was about 70% of that were 60 years or older. We had about little less than half female, whereas almost over 3/4 of the sample were living in an urban area, and 24% of the APS clients were part of a dyad in the study, so their caregiver was part of the study. For the alleged perpetrators and caregivers, the median age was about 57 years old. 50% of them were 60 years or older. 3/4 of that were female, and 77% were living in an urban area, and 29% were part of a dyad in the study. Next slide, please. So we looked at depression. So this is once again from the research interviews, from pre-test interview and post-test interview. And we measured depression using the patient health questionnaire, 2 questions from that. And what we found was that for the APS clients, we found a significant decrease in depression from pre-test to post-test for the APS clients, but not for the alleged perpetrators and caregivers. Next slide, please. We also looked at anxiety using the generalized anxiety disorder scale, using the 2 questions from that. We found that, once again, for APS clients, we saw a significant decrease in anxiety between pre-test and post-test. And for the alleged perpetrators and caregivers, we did not see that decrease. Although we see a trend, it's not significant. Next slide, please. We also looked at a question about how much help they received. So they had 3 different responses. I receive the help I need, I receive I don't need any help, or I receive less help than I need. And we particularly looked at that last one, I receive less help than I need, and looked at the count of how frequently that was selected between pre-test and post-test. And for APS clients, we see that a significant decrease in clients selecting that option. However, for the alleged perpetrators, we do not see that decline as significantly. Next slide, please. We also looked at APS outcomes. So during the study period, there were 11 new reports to APS made for 7 APS clients. The range of reports were between 1 to 4 per client. Out of those 11 new reports, 8 APS cases were opened. 50% of those had the same alleged perpetrator. So there were 12 allegations in those 8 APS cases. So 2 cases had allegation of caretaker neglect, 3 for emotional and verbal abuse, 3 for financial exploitation, 3 for physical abuse, and 1 for self-neglect. However, no cases were substantiated. So 75% were found to be inconclusive, and 25% were found to be without merit or unable to locate. Next slide, please. For the alleged perpetrators and caregivers, for APS outcomes, so during the study, only 1 new APS report was made regarding an alleged perpetrator. The APS case was opened, however, the alleged perpetrator was reported as a victim of financial exploitation, so they were not re-reported as a perpetrator. And this was closed without merit, and no caregivers had a report made to APS during the 4 months of the study. Next slide, please. So just a brief summary of what I just went over with. So for APS clients, we see a significant decrease in depression, anxiety, and receiving less help than I need, so selecting that less. And about 18% were re-reported to APS. For alleged perpetrators and caregivers, we're not finding significant differences for depression, anxiety, or selecting the receiving less help than I need. However, we did find that 0% were reported to APS as a perpetrator. Next slide, please. Now I'm going to pass it on to my colleague, Tiffany Conway.
Hi guys, I'm going to be talking about 3 different cases that I worked with. Go ahead and switch slides. So the first case, this is at APS case closure. The client declined to allow investigator into the home. The client denied she needed assistance with ADLs and IADLs. Client appeared frail. Client was willing to explore services, and the case was closed inconclusive. The client stated she does not have a caregiver. The client did not want the alleged perpetrator interviewed for fear it would increase disharmony in relationship and increase hostility. Investigator identified the need for housing services. Next slide. So when I met with the client, we worked as a team. We built her service plan with her as the driver. So the very most critical need, it was housing. She was 2 weeks from being displaced, homeless. She has a terminal illness that really impacted her ability to stay in a shelter. So within 2 weeks, we were able to work together, get her a new house, and we actually helped pay for her deposit through ARPA funds. The thing is, there was this slight gap between when her house was going to be ready and when she was needing to be out of her house. So that was a lot. We were able to pay for a hotel for 4 nights. I, with the client's permission, was able to find some movers in her community that were amazing. They actually came in, they packed her house up. I called a storage unit, a storage place, and asked them if we could utilize a storage unit for 4 days, and they allowed it, and it was for free. It was one of those, if you rent the storage unit, you can get 3 months free. So that was such an amazing thing to happen. So once she got into her apartment, the movers came and actually helped her unpack and get her apartment set up, which was, she's pretty frail. Like I said, she has a terminal illness. But once we got her housed, then we had to actually set up new medical transportation. She moved out of a county into a new one. Her Meals on Wheels were started back up, and I advocated with her primary care provider to get some in-home care, because she identified that she actually was getting to the point where she needed it. And then she was able to transition into some palliative care. So she's stable and really she's living a lot better life and situation. That's what she reported to me, and it worked out well. Next slide. So the next case study is a daughter that's a caregiver, and then she's caring for an elderly parent. So the investigator met with both the client and the caregiver. No service plan developed, nor services identified. Risk level was assessed at thriving. Closed inconclusive. Client did not engage much with the investigator. Caregivers denied allegation, and financial exploitation was also investigated. Next slide. Okay, so these guys were really active in this research study. They were really wanting some support. For the person being cared for, he had lost a spouse recently, and he had his dentures were actually buried with the wife, and so that really impacted his ability to eat. We were able to purchase new dentures for him with ARPA funding, and also provide some clothing support because he had lost so much weight he had no clothes. The caregiver really needed some support with just when she moves forward after she's no longer a caregiver. So we've really focused on getting her record expunged. There was some criminal stuff in her background that prevented her from getting other employment. We also looked at credit repair. She's thinking, hey, I need to get a house eventually, and live out on my own. And so we looked at how she could improve her credit score. So they also needed some help with like rental assistance and energy assistance, just because any of their extra funding actually went to a funeral for the mother that had passed. I reached out. Her car, which is what they used for medical transportation, was breaking down. So I reached out to some local high schoolers. They have a shop there, and they actually were able to repair her car for the cost of parts, which everybody knows that's expensive when you have to pay for labor and auto repair. And then just helping her with what she wanted to do moving forward, job training and things like that. They both, when they ended the study, were stable and reported that they had everything that they needed at the time. Next slide. So the last one, but never least, this person, the client was a younger adult with some intellectual disabilities. He was found at a Walmart by family and taken into a DV shelter. When he was encountered by APS and law enforcement, he very, very limited communication abilities. Client was left with nothing, no identification other than the clothing he was wearing. Client was beaten and indicated his brother had caused the injuries. Client was not able to meet basic ADL needs. Case closed, inconclusive. Investigator arranged for client to reside temporarily in DSPD group housing. Case was closed with APS paying for the group homestay and no identifiable plan for long-term payment or responsibility. Next slide. So this was incredibly, probably the most challenging case I'd ever come across. This person was a member of a Utah cult that did not believe in registering their birth. So every child born usually is born at home. No formal schooling, no doctor's appointment. This person never existed. So the question I asked myself when I got this case was, where do you go when somebody does not exist in this country? There's no record. Well, you contact your senator, because that's exactly what I did. And a Utah senator actually helped me immensely in this case. I can't even tell you where we'd be if he had not stepped in. So some of the big barriers that we face in this case was, well, APS can't keep paying this group funding, this group housing situation. So finding him appropriate living was like the biggest goal I needed to accomplish. And I actually found this, it's a skill building group home that specializes in human trafficking, and they actually took him in. He had to have intensive trauma therapy because he was so traumatized he wasn't actually speaking very well. And so just working him through that so that we could actually work together as a team and get him the services he needed. He did end up, with the help of a senator, we had to go international because he was born international, apparently, and obtain records and documentations to get a passport for him. So it took many, many months, but we did get him a passport. He is learning how to life skills. He has food benefits now and Medicaid, and he is utilizing therapy services. He was able to get full dental restoration, which was phenomenal. And then he has peer support people now working with him on getting SSI and things like that. So it was challenging, but you know, a lot of hard work, and we were able to overcome some just barriers you never really think about until they're right in your face. So yeah, I'll turn it over to Courtney. Thanks.
Thanks, Tiffany. Next slide, please. So I'm going to lead a little bit of a discussion about everything that's been presented so far. Next slide, please. So we've had a few challenges and we've learned some lessons along the way. We are currently wrapping up data collection in the study. We expect that to happen early next year, early 2025. One of the first lessons we learned, Farida talked about it earlier, was the study design. It was changed from a randomized controlled trial to a pre-post longitudinal design, which she described. And that had a lot to do with the logistics of recruitment. And as part of the recruitment lessons we learned how valuable it is to simplify consent forms and to shorten interviews. We also learned that staff turnover takes place, and it's really important to find the right fit for a project. And when we found the right fit for different positions, recruitment became much less of an issue. And so we have been very grateful with the staff that we have. You've seen some of us here. I want to take a minute and just thank the rest of the team. Tracy Lee is our project director at the Utah Department of Health and Human Services on the project. Ariana Patterson is the other care coordinator, and then Erin Orchard and Donna Salam are our research assistants, and they have been wonderful to work with. And so we found our right fits, and we're very grateful. And then we also, because of the staff turnover, we learned some things about contracts. So there were periods of time where we needed to update our contract to be able to have access to personal identifiable information for recruitment. And so that took time. And so that was a lesson that we learned, is just making sure we have time for the appropriate contracts and making sure everyone has access to the information that's needed. Next slide, please. So I don't know about all of you because I can't see you, but you can see me. And I love watching Tiffany and our other care coordinator, Ariana, talk about the people that they work with, their clients. And when we think about the successes of the project, one of the things we think about is, how does this impact people individually? And so this is a quote about a participant's experience with Tiffany specifically. And I'm just going to read it because I think it tells a lot. So it says, "I feel a lot better with everything we've done with the Benjamin Rose Fund for what they've done in our home. Tiffany has helped so much. I've been to every doctor and I feel 100% better. Tiffany's help was priceless. I also give myself a lot of credit because I learned that if I take care of myself, that is taking better care of my loved one. I am taking care of myself again." How amazing is that this is, to me, this is a successful outcome in this individual's life, and they've been able to help their loved one because they've been helped themselves. And I just want to say here as a caveat, this was not the Benjamin Rose Fund, although the quote's recognizing it as again, this was a project that was funded by the Administration for Community Living, but that is how the person who gave us the quote identified the fund that provided them gift cards for participation in the study. Next, oh, I'm sorry, that funded the study. Caregivers and caretakers did not receive gift cards as part of the study. Only clients did, APS clients did. So that's an important caveat to mention here. Next slide, please. So now if we want to take a look at the implications beyond individuals, if we look at practice, what we've learned so far from the study is that telephone-based case management is possible for APS clients after case closure. Not only is it possible, but it's possible at a state level. The care coordinators on this project are providing case management services to adults throughout the state of Utah in both urban and rural and frontier areas. We've also learned that dyads are interested in receiving help. Once they're invited to the study, typically, unless they ask to be interviewed together, all of the research processes take place separately. So the clients are getting help, and then the caregivers or the caretakers are getting help separately. But what we're learning is that they are interested individually in getting help. We've learned that the psychosocial outcomes appear to improve over time for alleged victims of caretaker neglect, and this is really exciting. And so we are hopeful that in our final sample, we find the same thing, but it is important to note that these are preliminary results and they're based on a small sample. Next slide, please. So the implications for policy are that if this proves to be effective in Utah, the state will look for ways to sustain the program. And other states may be interested in creating similar programs where they are, if it does prove to be effective in Utah. And one of the things that I think in terms of the preliminary findings that was very interesting and important is the fact that of the alleged perpetrators or the caretakers and the caregivers, none have been re-reported to Adult Protective Services during the study period that we know of. So that's a pretty big policy implication in terms of wanting to replicate a program like this. Next slide, please. So our next steps in the study are, like I said, we're still in the data collection phase. We plan to end that early next year. And at the same time, we're cleaning and analyzing data. We finished all of our baseline interviews, and so we're starting to clean and analyze that data, and that's what we presented from today. We are identifying lessons learned. So I talked to you about a smidgen, a small percentage of the lessons that we've learned. There's been a lot in this study, and we're excited to share them in our final brief and report to ACL, the funder, and also in presentations and publications to come. And we see that there's a lot of potential for future research here in the area of post-APS case closure, in the area of caretaker neglect prevention. So we're pretty excited about the findings that we're finding, and also the possibilities that, you know, this could be a very real intervention that helps people in the future, just like it's helping people right now. Next slide. So now we are ready to take some questions and answers. And I'm going to go ahead and mute myself. And we appreciate you taking the time to listen to us.
Okay. If anyone has any additional questions, please feel free to type them into the questions box, and I will repeat them for our presenters. Thank you all very much for your time today. The only question I have so far is what follow-up is planned with the participants now for any kind of like long-term data collection on outcomes. Farida, you are muted.
I could take that. Right now, we are just part of a study, so the sustainability plan will be discussed with Utah APS, as well as APS administrative staff, as well as if we could make connections with the AAA staff. So all of that is a plan for the future. I don't know if Tracy is on the call, if she wants to add anything. Tracy Lee, our project officer in Utah.
She would be muted and would have to type her any comments that she has in the question box, but I'll be sure to share them if she does that. There was another question. What was the process to partner with care coordinators, care providers, etc.? MOUs, MOAs, what was the process?
So we had all of the above. We had contracts, we had a data use agreement, and those were Can you hear me? Okay. And there were, contracts had to be revised, like Courtney mentioned, because we thought we had a very comprehensive contract which had specified that we would need client information, including their name and date of birth, address perhaps, but when Utah realized how they gave us some of the access, there was a clampdown, and then we had to re-revise and make the language more clear that we would have access to this PHI information. So it was a learning process, and part of the reason why it took longer than usual. I shouldn't say longer than usual, because every study that I've done so far in the last 12 years or so with funding from ACL, contracts are a big issue. And if you want to talk to us offline, we'd be happy to tell you a little more about that. Does our team want to contribute anything to what I just said?
Tiffany, do you have any information about, in terms of working with the local agencies, though, that was based on the relationship that the Department of Health and Human Services already had in place, right? So I know Tracy is listening, and she may add to the chat here, but in terms of the care coordination piece itself, the organizations that the care coordinators worked with, Benjamin Rose did not have relationships other than with the Utah Association of Area Agencies on Aging. We did not have individual MOUs or agreements with them. We had an agreement with the state of Utah to do the project. And then the care coordinators used existing relationships by their organization to provide the case management services.
Yeah. So, I know for a lot of my clients, there was a lot of people that had Medicaid. And so just reaching out to the managed care organizations and opening up a conversation, putting in a referral, that actually developed into a really nice partnership. Now we do MDTs, and a care coordinator sits on an MDT, and they'll staff cases. I've staffed cases, all of us have. And so that right there really builds a nice relationship with community partners. The AAAs, they're involved in that as well. And it's just putting it out there for us to partner and build a space of trust and, mutual goals of, helping our clients. So I know that when I started versus now, the relationships I've built they're invaluable at this point. They're just, we have to have them to really give everybody a solid foundation and meet those goals with the clients.
Okay.
I know that Tracy Lee was typing in something in the chat.
Yes,
are you able to see it? Okay.
I was going to read that for you. So Tracy's comments: we are already sustaining the program and have added caretaker neglect cases to our post-investigation services. Currently, we are using our remaining ARPA funds, but plan to sustain the program through Medicaid claiming. I think we anticipated we use the AAAs more, but have found that the care coordinators have utilized other services like managed care through Medicaid and Medicare. And then currently, any client with a supported or inconclusive finding with Utah APS is offered care coordination after investigative case closure. Those are our comments. We do have a couple more questions I want to get to. What is the case closure process? What is the process? I'm sorry. What is the process for case closure in Utah? And I think that's probably for Tiffany.
Yeah, that's a Tiffany or a Tracy question.
I don't know if Tiffany had a...
Yeah, I'm here.
Okay.
Yeah. So basically, the investigator, comes in and they'll do their investigation, and they'll offer services too, or they'll build a service plan. But if they're not finding anything that they can substantiate, they'll close the case and then potentially refer them over to care coordination. So I don't have a lot to do with the case closure part of it. I get them afterwards.
Okay.
I want to just add something here about the research that we're doing. So one of the things that we are looking at in the research is the services that were offered. And we're tracking at case closure what services were offered to the participants in the study. And then we're also tracking the services that are offered at each of the interviews Farida described. So our hope is to have more information about that as we clean and analyze the data in the next year or so.
Okay, we have a question from California. We just have urban and rural areas. What does frontier mean?
It's like super rural. So I'd have to look up the exact definition in terms of density, but it's less dense than a rural area. So it's really, really sparsely populated land.
All right, now we have a question from Colorado. How does this study differ from the services that your APS caseworkers already put in place during their investigations?
Well, basically, we have 4 months to intensively case manage. So investigators, you think about it, they probably have pretty big caseloads, and they can't spend as much time as, say, me. I'll have clients every single day. We're talking, and pushing towards their goals. And, granted, it would be beautiful if APS investigators could do that. It's probably not something they could do. So it's just an intensive care coordination, case management type situation where I that's my job. I focus on that goal. And investigators, they have so many different pieces to their job. It's just not feasible to spend as much time that I do on them, on each client.
The other question is that the services may be similar, but once a case is closed, we sometimes don't know what happens in the long term. So this project is a post-case closure intervention, and we are tracking outcomes after APS closes a case, 4 months. Ideally, like we saw, we didn't make so much of a difference in the lives of caregivers. And we think it's probably because they are overwhelmed, perhaps very overburdened, stressed, and they need more time in their busy schedules to take care of their relatives. So perhaps for the caregivers, the caretakers, we need maybe a longer intervention, maybe 6 months, maybe a year post follow-up to see outcomes that would benefit them in the long run. We saw clients like talking to the caseworker, to the case manager, the care coordinator, and we saw immediate improvements. And by immediate, I mean 4 months, within 4 months, post-case closure. But there's more to learn from this study. So although services may be the same, you're right, that what APS is offering, we may be replicating some of those, but it gives us a longer term window to work with them.
And also you really build I've heard consistently, it's a little scary for clients to have an APS investigator, in their living room. And so I'm separate from that. And you actually, when you start building that rapport, you get this, I had one client that's like, I need nothing, but in reality, you know, they needed some DME, they needed wound care, they needed a whole bunch of stuff, but they were so worried about getting their caregiver in trouble that they didn't open up to that level with the investigator. And it's no fault of the investigator. It's just, I think it's a natural reaction for some people.
That's a good point. Okay, I have a couple more comments from Tracy, and then I have another question. So from Tracy, the APS investigator looks at current allegations of maltreatment and determines their finding. They look at needed services to meet the protective need and identify them in the service plan. Then the care coordinator will pick up that case if the client consents and help connect them to the identified services. The care coordinator drives the program through self-directed services by the client. We also use the ISO matrix to identify risks associated with the victim and try to help the person get connected to those services. Often, the APS investigators do not have time to provide short-term case management. They can make referrals, but the care coordination program helps with warm handoffs, filling out applications, navigating complex systems, and ensures that before their case is closed, that person has services open and running. And then she responded to the frontier question. A frontier area is a remote and sparsely populated region, often defined by its distance from population centers and services, defined by 60 minutes or 60 miles along the fastest paved road. Okay. So after that, I do have another question. Clarification. Phone case management services was provided by APS, or was case management contracted out with another agency?
So the care coordinators were hired by the project. They didn't have to be APS staff. An ad was placed and we hired case managers to take over after APS investigation was over. So they were not APS staff. But a state could experiment if they wanted with assigning some APS staff to do longer term follow-up after a case is closed by APS. So in our model, they were not APS staff.
Okay, next question. The survey outcome data showed decrease in client depression, anxiety, received help needed, etc. Would you know why there was not the same decrease for caretakers / caregivers?
So I think it's caretakers, caretakers and caregivers are a more complicated group. There's a wider range of types of caregivers that we're seeing in caretakers, so there may be that playing into it. So I think I know we're helping them, but clearly by the impact that Courtney read of the statement by the caretaker that we have received. So I think it's just a matter of taking a deeper dive into the data and really trying to tease out the findings and finding those differences.
We also have to look at the reason, the relationship between helping caregivers and its impact on clients. Because although the caregivers didn't have statistically significant differences, one of the positive outcomes they had is that they weren't being re-reported to Adult Protective Services during the course of the case management. And so that's a pretty big deal. And so that was a positive outcome from the study, but we also need to look at the relationship between what's happening within the dyads to see if it's influencing the positive outcomes we're seeing among the clients.
Also the fact that the services, there's not a lot of services that are directly related to caretaking and caregivers. So a lot of the services were directly related to the APS clients and not necessarily directly there to help the caretakers.
I also have seen that when I'll meet with caregivers their first reaction is, I just want you to help my, their parent or whoever they're caring for. So, it's beautiful in the way that they are like, I just want you to focus on this right now. And you really have to kind of walk them back and go, we are helping them. How can we help you? That's what we want. And it's hard for some to actually go, well, a lot of them go, well, I don't know what I need right now, or and so it's working with them. And 4 months is a short period of time, and so you're building a relationship, you're working as this team, and it's just trying to get them to open up enough to go, okay, this is actually what I really need. In that case study, it took 2 months, the one that I presented with the caregiver that needed, her record expunged and things like that. It took 2 months of me calling her, and asking her that question. And then I'm like, yes, that's what I want to know. Let's point you to that direction. And so yeah, I think Frida had a good point of maybe extending the caregiver part out, just because it does take time for these folks to open up enough to say, hey, this is what I really need.
The other encouraging thing about the study, as you can hear, is that our partner, Tracy Lee, our project coordinator in Utah, said they're already sustaining the program. They're already building it into their APS system, their plan, which is really very encouraging to us as researchers, because our job is to test a pilot and to try to improve practice. Sometimes those improved practices are not sustained. And so if it's going to be sustained by Utah, in a year or two, maybe Tracy would be doing this webinar. Tracy and Tiffany would be doing this webinar to say, what happens to clients once the program is institutionalized and becomes part of everyday practice.
Well, I think Tracy has another comment where that kind of speaks to that, Farida, because she said that the care coordinators are all APS staff, so she considers them part of the team. So
I'm
that,
mistaken. I thought we hired them. We were there as part of the interviewing process, so I thought they were external. I'm sorry about that.
No worries. Okay, that is all the questions that we have, and it's right on time. So can we go to the next slide, please?
This is just our contact information if you want to get in touch with us. Those are the references that, some selected references that we cited in our study, in our presentation today.
And I think the other last thing I would like to say is that this is a team effort. And you can see some of the researchers are away from the practice side. So it's important to include all of us when discussing something so that we have this research practice partnership.
I couldn't agree more, Farida. I want to thank everyone for your time and attention. Here is the contact information for the APS TARC. If you ever want to reach out to us, here is how you can. You can follow us on social media. And of course, if you are interested in seeing past webinar recordings, you can find those on our YouTube channel. I really, really want to thank our presenters today from Benjamin Rose and from the Utah Department of Health and Human Services, Courtney, Farida, Samantha, and Tiffany. And with that, I will wish everyone who celebrates a very wonderful Thanksgiving, and thank you for your time. Have a great day.
Thank you.